though we're expecting a lot more people to join a little bit later. Good afternoon, everyone. Welcome to the Department of Geriatric Medicine Grand Rounds. Before I introduce our speakers for today, I have a few housekeeping items. This CME activity is sponsored by the Hawaii Consortium for CME, a joint venture between the Hawaii Medical Association and the John A. Burns School of Medicine, University of Hawaii. At this time, please enter the name and credentials of everyone viewing Grand Rounds for CME attendance purposes. As a reminder, evaluations are required for CMEs. You can find evaluations by following the link in the chat or on the website or in our email advertisement. Your comments are very important to the planning committee and will be used to plan future programs. As you know, all sponsors of CME are required to execute a conflict of interest policy. Speakers are expected to disclose to the audience any real or apparent conflicts of interest that may have a direct bearing on the subject matter of the program. All our speakers today have disclosed that they have no relationships with commercial supporters that could be perceived as conflict of interest in the context of this presentation. So I'll move on to introduce our speakers. I want to say this is my favorite Grand Rounds of the year every year. This is where our fellows are presenting their research and quality improvement projects. This year's fellows have worked very hard on their projects, and I know you will all really enjoy their presentations. So our first set of presenters, we'll have 3 of our first-year fellows who are presenting on the Fellow QAPI project. Every year, our fellows undertake a new quality improvement project, and they'll be presenting the results of this year's project. Our first speaker will be Dr. Ashok Kannan. He completed medical school and residency in internal medicine in Pennsylvania. He has a special interest in health systems and quality improvement, and he really took the lead in the Fellow QAPI project this year. His hobbies include hiking, tennis, and most recently, I heard he started sailing. We are very lucky that Ashok will be staying for a second year of fellowship. He's opted to do that. The second speaker for the QAPI project will be Dr. Ji-Yoon Kim. She completed medical school in Nevada and family medicine residency in Orlando, Florida. She loves all of geriatrics, but her special interests include falls and fall prevention. She left Oahu when she was in middle school and returned again for the Geriatric Medicine Fellowship and fell in love with the island all over again. We're really happy she came here. And after graduation, Ji-Yoon is joining the Queen's Geriatrics team. The third speaker for this first project will be Dr. Valen Chong. She's a graduate of the John A. Burns School of Medicine and completed her internal medicine residency training and also served as ambulatory chief resident at the Kaiser Permanente Hawaii program. She enjoys being outdoors with her dog Winter and trying new restaurants with her husband. After graduation, she will be joining Kaiser Permanente again. So all these 3 fellows will be presenting the QAPI project for the fellows for this year.
All right. Let me go ahead and share screen and start, Dr. Masaki.
Yes, please go ahead, Ashok.
Okay. Of course. Okay. So. All right. Is my screen visible?
It's fine.
All right. So my name is Ash. It's a pleasure for me to present this project along with all the fellows and the faculty that were involved in QAPI, as well as over at QAPI, all the staff and some of the administration. So our project was improving telehealth during the pandemic over at QAPI Geriatric Care. I'd like to acknowledge all the authors and the support that was given to also present this project this year at AGS. We do have no commercial conflicts of interest or disclosures to report. So as an initial introduction, we know how hard telehealth has been implementing telehealth at nursing facilities during the pandemic particularly, and we found that there's 3 main factors that other groups have also sort of defined as the building blocks of telehealth implementation or rapid telehealth implementation during the pandemic. And it includes a stable telehealth infrastructure, rapid integration into the daily workflow within nursing facilities, and rapid adaptation by facility staff, the residents, and the care providers, which includes training. Now, knowing that at QAPI, the adoption and implementation of telehealth was still meeting significant challenges, so that's what we took on at KGC. That's what we took on as our QAPI project. So at a glance, we started with the root cause analysis, implemented an intervention, identified a bunch of barriers and addressed those barriers, and then we had data collection and analysis. And I'll just introduce those 4 parts to you. For the root cause analysis, it's hard to see the words on that paper, but basically that was our needs assessment survey that we devised. That was a fun part of our project because we were able to put together that needs assessment, I think for most of us the first time as a group as fellows, and figure out how best to create a needs assessment survey. And from that survey, we got responses, and those were free responses, and they were coded into themes or areas needed improvement. So we took each idea and coded it into themes. We use a plan, do, study, act cycle, and we're one of the models for QAPI projects. And so that PDSA cycle was implemented in the initial planning phases as well as the implementation phases. So we identified multiple interventions that would best address the areas that needed the most improvement after we identified those areas of improvement. And then we met with the stakeholders over and over through this PDSA cycle to refine interventions, and then we implemented those interventions. Now, we had multiple issues that came up, and those are the barriers identified and addressed. So the initial things, 2 weeks into the planning phase as we started the project, we realized that the project had 2 separate issues that we needed to address separately. So that was telehealth scheduling, the actual scheduling work, the scheduling sort of protocol that went from the physicians or the nursing home needing a visit scheduled for a certain patient to executing that visit, and then the workflow itself for the visit. And the way we address those issues is that the fellows largely took over the telehealth visit workflow component, and to improve that, and the QAPI faculty largely took over the telehealth scheduling component. And then about, one of the major issues about 1 month after implementing the interventions, so this is after with the PDSA cycles, and then we came up with interventions based on the needs assessment survey and started implementing the interventions. We found out, okay, we implemented interventions in the way that we wanted, which will sort of be talked about a little bit later. And we found out, okay, for scheduling, nurses were still unaware of many visits, so the scheduling protocol wasn't as impactful as we were hoping initially. And then the visit workflow, all the nurses weren't totally aware of the intervention itself. So even though we implemented an intervention, and the implementation didn't seem to be that successful. So we went back and talked to the staff champion over at QAPI Geriatric Care and said, okay, can we work on reinforcing both of these? And they said, okay. So we said, okay, we'll check back in a few weeks and see how it goes. So about 2 months after implementing the intervention, we said, okay, well, we still had an issue. For the scheduling process, the nurses were still unaware of the multiple visits. When I say unaware, they were unaware that they were supposed to happen, and they were unaware that they were when exactly they might have been, or it just might have been hard for getting that day's schedule together and really getting everything together. So then when I say UC, as unit clerk, each unit clerk had their own interpretation of the implementation that we had asked to, the protocol that we had made. So we found out that was an issue. Now for the visit workflow, the intervention was there, but it's still not being used consistently. We'll talk about what that intervention was. But basically, we still had issues 2 months later, and that was with the implementation of the intervention. So the fix that we decided for scheduling we'll focus on this part. We ended up calling each unit clerk individually and reviewing the process and the concerns that they had. And they put out, they had a few concerns, which is why they were each doing it separately. They had their own interpretations. So we walked them through that and tried to make it more consistent across each floor. And then for the visit workflow itself, for the actual telehealth visit, we also talked to each unit clerk and each nurse. At that point, we talked to each and every one. We reviewed the process and the concerns and really reinforced it with every single person from our perspective, not just through the KGC champion. So at this point, we had the KGC staff, administration, the champion helping, as well as us also reinforcing. We made a training video. We made that training mandatory and brought snacks as a thank you. So that was for implementation. And after all that, we had success for implementation of our interventions, meaning they were all being used in the way they were intended. And after those interventions, we had qualitative and quantitative outcome measures that were planned along with the project. Initially qualitative, those themes that we were talking about where we had a needs assessment and there were common responses, we put them into themes. We assessed those and we did an assessment before and after intervention. So we have those free response themes, and then we have quantitative, which included a 1 to 10 Likert scale satisfaction score, pre and post intervention. So just satisfaction with telehealth and different components of telehealth. And that was from a retrospective pre-post survey, which was analyzed with using paired t-tests. And then we also looked at the number of weekend call ER transfers 4 weeks pre and post intervention. Basically, we had recorded ER transfers from on call on the weekends. So we had those numbers. So we thought, okay, let's use the numbers to try to compare if we affected ER transfers at all after the intervention. And I'll let Gian take over.
Thank you, Ash. So continuing where Ash left off, so this is the needs assessment survey that we had talked about already. So this, we created a qualitative survey to assess any issues that existed with the telemedicine visits. And then the survey addressed if there were any concerns regarding any issues, including scheduling, equipment issues, data collection done by the staff, the exam, and the effect on the trainees. And then this survey was then provided to the nurses, LPNs, the attending physicians, along with all of the geriatric fellows. And then the survey was given out before and also after the implementation of our standardized worksheet that was used to collect data by staff. Next slide, please. And then, so this is the standardized telehealth form that the geriatric fellows all worked on together to create. And it's kind of hard to see, but we took input from the attending physicians about things that they thought were pertinent and they would want included in their telehealth visit. And then this was done to have completed by the nurse who was taking care of the patient that day, preferably before the telemed visit had started. And then this helped to standardize all of the information that was gathered prior to each telemed visit and included vitals, review of systems, a standardized exam, and then trying to capture as much of the pertinent information that all the attendings had wanted, such as new falls and a lot of several other geriatric review systems. Next slide, please. And this is the qualitative results. So from the survey, and this is before any of the interventions were applied. And then what we did was we recorded the most common responses that we found from the surveys from everyone who had filled one out. And then we followed that by the second most common response for each domain. So when you take a look at it, you can see that in scheduling, the most common response that we got was that the telemed visits were interfering with the nurses' other daily duties. Poor Wi-Fi was also a big concern. And then also concern that the exam that was being performed by the nurses would be or were different from how the provider would have performed the exam, and then that all of the exams were not very standardized. Next slide, please. And then so this slide shows the different interventions that were applied, and some of them Ash had already spoken about, and several of the interventions that were carried out, they were done by different members of the team. And so one thing that we had done is that each attending had a designated Zoom meeting number. So this helped to prevent any confusion with the nurses having the correct Zoom link for each attending. Also, there were additional Wi-Fi access points that were installed at QAPI, and then also we had additional iPad tablets that were obtained as well. And then also the slide prior, we had seen that the fellows, we had created that standardized worksheet for the staff to fill out prior to all of the telemedicine appointments for the patients. And that helped to kind of streamline everything for the nurses and for the providers. And then also it was nice because the nurses were allowed to use that form after they filled it out as their clinical note to help streamline their workload as well. Next slide, please. So on this slide, we have the pre and post intervention qualitative results. We already saw the top portion a couple slides prior about the issues, the most common issues that people had prior to the interventions. And then if you look below, we have the results now after the interventions were applied. Again, we did the same where we recorded the most common response and then followed by the second most common response for each of the domains. And then you can see that there was improvement in equipment and technology domain, where poor Wi-Fi was a response seen 57% in the pre-intervention, and then it went down to 22% after the intervention. Also for scheduling process, prior to the intervention, we saw that 70% of the responses were that the visits were interfering with nursing duties. And then post-intervention, we can see that it dropped down to 39%. And with that, I will pass it on to my co-fellow, Fallon Chong.
Thank you, Jian. So I will be covering the quantitative results. As mentioned before, a retrospective pre and post questionnaire based on a Likert scale was given to physicians and nurses to assess changes in satisfaction with the telehealth process based on the following domains as mentioned before. Here are the results, which you can see are all statistically significant. The results I want to highlight are the domains that received the highest ratings after intervention, which were equipment at 8.3 and clinical information at 8.2. Clinical information also had the largest difference between pre and post questionnaire at 3.2 compared to the other domains. However, I do want to note that this question was only asked of the physicians. The telehealth worksheet helped to streamline the collection and presentation of pertinent clinical information from staff to physicians for effective and efficient telehealth visits. Lastly, the overall satisfaction after intervention greatly improved from 6.2 to 8. Next slide, please. We also reviewed emergency department transfers pre and post intervention and noted there was a large decrease from 25 visits to 7 visits. However, we acknowledged that there were a lot of confounding factors such as time of year, staffing changes at the facility, and acceptance of patients during the COVID-19 pandemic. Next slide, please. So in conclusion, we conducted a QAPI project to improve workflow of telehealth visits in a teaching nursing home, especially during the COVID-19 pandemic where in-person visits were restricted. A needs assessment survey of nurses and physicians revealed areas that needed the most improvement, including scheduling process, equipment and technology, clinical information provided to physicians during a telehealth visit, physical examination, and trainee learning during telemedicine. Complete implementation and adoption of the interventions took 4 PDSA cycles over the course of 3 months. Challenges included the need for continued reinforcement, workflow integration, and training at a time when the facility was also focused on complying with continuously changing requirements due to the COVID-19 pandemic. Next slide, please. However, in spite of all of these challenges, it was critical to push ahead with interventions to improve the processes of telehealth scheduling and workflow to optimize staff and patient safety. Our efforts led to significant improvements in satisfaction scores in all areas of the telehealth process. Previous work suggests that efforts like these to continuously improve user satisfaction with telehealth may lead to better communication and better health outcomes. This highlights the value of considering telehealth improvements in future efforts to improve patient outcomes in nursing facilities, particularly as telehealth becomes a routine part of our post-pandemic world. Next slide, please. As for future directions of our QAPI project, there could be consideration of performing another PDSA cycle to assess for further areas of improvement in telehealth visits. This workflow can also be applied to specialists who would be willing to do telehealth visits at KGC. And as restrictions for face-to-face visits are lifted and physicians are now seeing patients in nursing facilities, how to incorporate telehealth visits as a continued option with consideration of scheduling and workflow between the two types of visits. Lastly, although the telehealth worksheet was more for during telehealth visits, it can also be considered for face-to-face visits to optimize efficiency. Next slide, please. I also do want to note that the fellows learned many lessons during our QAPI project. One of the most effective lessons that we learned was how to create a simplified process map with the guidance of Dr. Aida Wen. As you can see, our initial process map was very complex with multiple steps showcased by the image to your left. However, once it was simplified to just 4 steps, it was easy to determine the mini steps for an effective intervention, as shown by the image to the right. Next slide, please. The fellows would like to give a special thank you to all the people who assisted us in our QAPI project, particularly the leadership and staff at Kuakini Geriatric's care. And we also want to give special thanks to Jojo and David, who were our KGC champions. Thank you so much for everyone for listening to our QAPI presentation. We hope you enjoyed it.
Fellows, thank you so much. That was a wonderful presentation. We do have a few minutes for questions. Do any of the audience have questions for this particular project? Please type them in your chat box. I think Dr. Fishberg has a good question. He said, excellent presentation all. Would the presenters care to comment further on the impressive reduction in ER referrals?
It is 100% due to our QAPI project, actually. Dr. When we presented this AGS, Dr. Misaki and I were talking, and with the ebb and flow of the actual increases in COVID infections, and it seemed to kind of that seemed to be confounding it, and there's just so many things happening at the same time. Basically, I don't know. And we really don't have a good answer for it. There's so many different things in that I don't think we can make any speculation. But we had that, so maybe we will go do some sub-analyses. But there's not even enough information really to do all that, so can only speculate. And I don't speculation wouldn't be smart for me, at least. I think Dr. Misaki might have more insight, knowing the island and how things go from year to year and things like that. But there were a lot of confounding factors. But with the ebb and flow of the COVID infections increasing and decreasing, so it was hard to tell. And maybe there's also the fact that we also as fellows are managing much of those ER transfers over time, and we're later in our fellowship as well. So I was thinking that might be one of the factors, maybe.
This is Aida. One of the things I just wanted to say is that, it is our hope that perhaps utilizing telehealth visits during, on call or during emergencies and stuff like that, especially maybe in rural areas, maybe it would, in fact, reduce ED visits. And it's something worth exploring in the future, the potential role for that, whether we are in the pandemic or not. So that's an area to explore further as a model of care, maybe.
There's a comment from Dr. Okamoto, maybe it also helped with infection control at KGC. And that's certainly one of the big reasons why telemedicine was implemented. So yeah, thank you, Dr. Okamoto, for that comment. Dr. Takenaka has a comment, wonderful on-call teams with fellows, good communication skills on nursing home teams, and lower census in general during COVID. I think we saw that at many nursing homes, particularly when there were positive cases and admissions were shut down for a while. Dr. Wong has a comment, in the midst of all the chaos, how were you able to get staff and admin to work with fellows? Fellows, do you want to field this one?
I can take this question. Hi, this is Valen. As we mentioned before, we had two champions at KGC, which were Jojo and David, and they were very instrumental in being our partners and helping us implement the project. However, we also had a champion on the fellow side, and that's actually Ash. We're so appreciative of him for having such a strong interest in QAPI and really being a leader for us to follow in leading this QAPI project. Examples that Ash did is that he actually personally called every floor himself to check in on how the interventions were going, if there was any feedback. He also helped split up the work amongst the fellows where, we would take turns in actually surveying the staff as well as our attendings with these needs assessment surveys and questionnaires. So it's definitely a group effort, but it was also because of our strong leadership.
Thank you, Valen. I think you hit the nail on the head. Warren, it was very challenging because they were so distracted by so many other demands. Every week it seemed like there was some new requirement being broken on them by either national or state leadership. So it was hard, but we were very happy and very grateful to the Kokini staff for cooperating and helping the best they could in a very difficult circumstance.
And I'll just mention that.
Yeah, go ahead, please.
Yeah, one of the things that Val's not mentioning is that we planned everything and everything and brought everything together, but all those calls were very necessary because they don't know us, and we also, one of the hardest things was they've never really seen us in person. So when we're calling and trying to talk to them, they don't really know who they're talking to, and whether they're even asking like okay, we have this worksheet, but were you the one working on it? They don't know who was working on what. And who's calling. So Valen, we devised one strategy to actually bring a bunch of food in person, so Valen could actually have her face there and say, hey, we support everything you're doing, thank you, and this is actually me. So during the pandemic, being able to show our face for nurses who are working so at at the they're so time limited and they have so many things going on. And a phone call is just a phone call for them because they have so many phone calls going on that I think that actually made a huge difference, being able to finally just show in person. And even though it's such a small thing and everyone knows that's a big thing, actually I think that was one of the defining points in our project where we were able to make a huge leap, being able to actually show our face and make that difference.
Great, thank you, fellows. I think we'll move on to the next presentation. So while I'm introducing the next speaker, Kohei, if you could start sharing your slides, that would be great. So our next speaker is Dr. Kohei Hasebe. He's originally from Japan. He graduated from Sapporo Medical University. He's certified in internal medicine and family medicine in Japan. And then he completed the UH family medicine residency, and he wanted to deepen his expertise in geriatrics. After he graduates, he's planning to go back to Sapporo, where he hopes to improve the quality of care for older patients. And this is his research project. He did data analysis from the Honolulu Heart Program. And if any of the Honolulu Heart Program staff are on this call, I just wanted to shout out to them a big thank you for helping a lot with trainee projects. It's all yours, Kohei.
Okay, thank you, Dr. Masaki, for introduction. Um, can you hear me okay?
Yes.
Okay, good. Okay, so thank you everyone. Good afternoon. This is Kohei Hasebe. I will present our research. Impaired standing balance predicts 29-year mortality in community dwelling older Japanese American man from the QAPI Honolulu Heart Program. I'd like to acknowledge my co-authors, especially Dr. Masaki. Thank you for all assistance and guidance. Okay, sorry. Okay. Then this study is supported by QAPI Medical Center and National Institute of Aging. We don't have any conflicts of interest to disclose. Previous studies have identified several physical performance measures as independent predictors of life expectancy and mortality risk, such as gait speed, hand grip strength, and timed up and go test. Meanwhile, studies have been inconclusive about predictive value of standing balance for mortality. Also, systematic review can be challenging due to differences in balance measurements. Studies are limited in Asian populations, and there have been no studies in Asian Americans. We conducted this study to explore the association between standing balance and all-cause mortality in a population of older Japanese American men. Our study population was QAPI Honolulu Heart Program, which is a prospective cohort study of Japanese American men in Hawaii that began in 1965. The baseline for this analysis was exam 4, which was conducted during 1991 to 1993. 3,741 men aged between 71 to 93 years participated. Participants were asked to stand in side-by-side, semi-tandem, and tandem position for 10 seconds each. After the exclusion of care home and nursing home residents, our analytic sample was a total of 3,613 men. For our outcome variable of all-cause mortality, there has been a comprehensive surveillance system since 1965, and data are essentially complete. Mortality data were available for almost 3 decades of follow-up, which is a unique feature of our study. Our predictor variable was standing balance, which we divided into 3 groups. The normal balance group were able to stand in the tandem position for 10 seconds or more. The slightly impaired balance group were able to stand in the tandem position for 1 to 9 seconds. And the very impaired standing balance group who were unable to stand in the tandem position at all. Approximately 75% had normal balance, 18% were slightly impaired, and 8% were very impaired. Baseline covariates were age, cardiovascular risk factors, including BMI, hypertension, diabetes, pancreas smoking history, physical activity index, total and HDL cholesterol levels, alcohol intake, and prevalent chronic diseases, including coronary heart disease, stroke, cancer, Parkinson's disease, dementia, or cognitive impairment. For analysis, we calculated age-adjusted mortality rate per 1,000 person years of follow-up and Kaplan-Meier survival curves. Multi-covariates Cox regression models were used to calculate relative risk for mortality adjusting for covariates. Cox models were repeated, excluding those with prevalent stroke, Parkinson's disease, and dementia at baseline, because these conditions are known to be associated with difficulty in balance. Moving on to our results. Age-adjusted means of risk factors demonstrated significant relationship between impaired standing balance impaired balance group and older age and higher rate of diabetes, rate of hypertension, physical activity index, total, and HDL cholesterol level were lower in the impaired standing balance group. Meanwhile, BMI, smoking history, alcohol intake did not show significant relationship with balance. Kaplan-Meier survival curves clearly show separation between the groups, where men with very impaired balance have a much worse prognostic trajectory, Men with slightly impaired balance are intermediate, and those with normal balance had the best survival. Almost all participants had died by the end of follow-up period. This separation in lines was more prominent at about 5 to 10 years of follow-up. This figure demonstrates age-adjusted mortality rates by standing balance groups. And the very impaired standing balance group showed a much higher mortality rate compared to the other groups. And you can see a nice dose response relationship, which was highly statistically significant. We did Cox regression models using the normal standing balance group as a reference. In the whole cohort, those with very impaired balance had almost 3 times the risk of increased mortality, whereas the slightly impaired group had a 37% increase in the risk. After full adjustment for age, cardiovascular disease risk factors, and prevalent chronic diseases, there was no significant association in the slightly impaired group over here. But the very impaired group still has 58% increase in the risk, which remains significant. The lower half of the table is subgroup analysis excluding subjects with prevalent stroke, Parkinson's disease, or dementia at baseline. Again, the increased mortality risk remained significant in those with very impaired balance. In conclusion, this study revealed that very impaired standing balance, defined as not being able to stand in a tandem position, was a significant independent predictor of all-cause mortality over almost 3 decades of follow-up. This association remains significant after multiple adjustments and also after excluding men with baseline prevalent stroke, Parkinson's disease, or dementia, which could have affected balance. Our study found that standing balance was a reliable predictor of increased mortality risk in elderly Asian American men, which can be easily implemented in office exam. Strengths of this study are a large sample size and population-based cohort study design with extended follow-up period. The study included men in the oldest old age group and was a unique cohort of Asian American men. Also, a large number of covariates were available for adjustment. Limitations include balance measurement at a single point in time, the observational study design, and male-only cohort, which limits generalizability. For the further research, translational studies are needed to identify how physical performance measures can be used in the clinical practice to improve prognostication and shared decision-making. Interventional studies to explore survival benefit of improved balance are also warranted. Thank you so much.
Thank you, Kohei, for an excellent presentation. Could we have 1 minute for questions? And in the meantime, maybe Crystal, you could put up your slides. If anyone have questions, please put them in the chat box while Crystal is getting her slides ready.
If no question, I can show you some interesting slides. So right side is standing balance and left side is gait speed. So standing balance is more like a distinguishing to evaluate prognosis for survival. Okay, thank you so much.
Thank you, Kohei. If there are no questions, you can still ask them at the end of this presentation, but I'll go ahead and start introducing our next speaker. Dr. Crystal Nishikawa went to medical school in Loma Linda, California, then completed internal medicine training at University of Hawaii. She enjoys surfing with her family in her free time. And after graduation, Dr. Nishikawa is unfortunately moving to California. She's going to be working as a hospitalist at Oroville Hospital in Oroville, California. They're lucky to get her. Go ahead, Crystal.
Okay, thank you, Dr. Masaki, and thank you everybody for joining us today in our grand round. Can you guys hear me okay?
Yes.
Okay, great. Thank you. So I'm gonna start on my on what I had worked on this year with Dr. Masaki and also a medical student at the time, Holly Harada. So this study is on loneliness and depressive symptoms predicting 8-year incident dementia in the Kuakini Honolulu Asia Aging Study. And I would like to acknowledge my co-authors. We have no commercial conflicts of interest. So recent studies have shown that depression and loneliness are each associated with cognitive impairment. Thus far, there have been no studies on the synergistic effects of depression and loneliness on incident dementia. Most studies have been in depression and mostly in white populations. So this study focused on whether depression and loneliness predict dementia and its subtypes in a cohort of older Japanese American men. And we used data from the Kuakini Honolulu Asia Aging Study, which is a longitudinal cohort study of dementia in Japanese American men in Hawaii from 1991 to 1993, 3,734 men ages 71 to 93 years old participated. And to avoid confounding due to baseline cognitive status or living conditions, subjects were excluded if they had the following: if they had prevalent dementia at baseline, or residents of care homes and nursing homes, men without a valid depression score or missing data on loneliness, and then those that were lost to follow-up. And then the final analytic sample then consisted of 2,651 men. These subjects were followed for 8 years for incident all-cause dementia, Alzheimer's disease, and vascular dementia, which is abbreviated as DEM, AD, and VAD respectively. And they were diagnosed based on standard criteria. The DSM-3R criteria were used for all-cause dementia. And the National Institute of Neurological Disorders and Stroke and Alzheimer's Disease and Related Disorders Association criteria, or the NINDS ADRDA criteria, were used for Alzheimer's disease. And then for vascular dementia, the California Alzheimer's Disease Diagnostic and Treatment Centers, or the ADDTC criteria, were used. At baseline, subjects were divided into groups based on the presence or absence of our predictor variables, depressive symptoms, and loneliness. Depressive symptoms were determined by the CESD-11, a questionnaire assessing for mood or affect, somatic and affective symptoms, and interpersonal relations over the past week, with each question scoring 0 to 3 with a total score range of 0 to 33. The validated cutoff score for depression was 9 or greater. Overall, there were 232 men, or 8.8%, with depressive symptoms. Loneliness was defined by a single item question about subjects' perception of loneliness, and overall, there were 279 men, or 10.5%, with feelings of loneliness. In addition, we created a 4-level predictor variable with 85.3% of subjects feeling neither depressed nor lonely, 4.2% having only depressive symptoms, 6% having only loneliness, and 4.5% feeling both depressed and lonely. Our analysis controlled for confounding variables including baseline age in years, education level in years, marital status, the ApoE4 genotype, defined as having either one or two E4 alleles, prior stroke, which was detected through a surveillance system that started in 1965, and baseline cognitive abilities based on the Cognitive Abilities Screening Instrument, or CASI, with scores ranging from 0 to 100. We did separate analysis for each of our predictor and outcome variables, consisting of Kaplan-Meier survival curves for incident dementia, age-adjusted dementia rates per 1,000 person years of follow-up, and multivariate Cox regression models to determine relative risk of incident dementia and its subtypes. This graph shows significant stepwise increases in age-adjusted rates per 1,000 person years follow-up for incident all-cause dementia and Alzheimer's disease across our four groups of neither depression nor loneliness, depression only, loneliness only, and both. As shown, there is an increase in incident all-cause dementia with values of 9.23, 16.23, 18.07, 25.31, and a p-value of less than 0.0001. The same trend is observed across the four groups for incident Alzheimer's disease, with values of 5.4, 9.93, 13.18, 13.89, and a p-value of 0.003. And then for vascular dementia, there was no significant association with a p-value of 0.4108. These graphs are Kaplan-Meier curves with depressive symptoms on the left and loneliness on the right, and the top graph of each for all-cause dementia and the bottom for Alzheimer's disease. We found that subjects with depression and loneliness, evidenced by the red curves, had a significantly lower probability of disease-free survival for both all-cause dementia and Alzheimer's disease compared to those without depression and loneliness, which are represented by the blue curves. Analyzing our four-level composite variable, we found for both outcomes, the group that had the best disease-free survival was those with neither depression nor loneliness, as seen in the blue lines. Next was those with only depression, as seen in the red lines, and next was those with only loneliness, as seen on the green lines. And the worst group was those with both depression and loneliness, as seen by the tan lines. No significant associations with depression or loneliness were observed for vascular dementia. A separate Cox regression analysis were performed for loneliness and depression to determine the relative risks of incident all-cause dementia, Alzheimer's disease, and vascular dementia. After adjusting for age, education, marital status, ApoE4 allele, prevalent stroke, and baseline cognition, the relative risk for incident all-cause dementia was 2.08 among those with depressive symptoms and 2.33 among those with loneliness, both of which were highly statistically significant. Likewise, the relative risks for Alzheimer's disease by depressive symptoms and loneliness were 1.94 and 2.41 respectively. No significant association was found between vascular dementia and either depression or loneliness. Cox regression models were also developed for the four-level composite variable. After adjusting for covariates, the relative risk of all-cause dementia was found to increase progressively across the groups of depression only, loneliness only, and both, using neither symptom as a reference. Depression only was associated with a all-cause dementia relative risk of 1.67 with a borderline p-value of 0.078. Loneliness only had a relative risk of 2.07, and both loneliness and depression had a relative risk of 2.87, with the p for trend as less than 0.001, which is very significant. Similar increases in incident Alzheimer's disease occurred across the 4 groups, with a relative risk of 1.8 seen among those with depression only, 2.51 among those with loneliness only, and 2.51 for both depression and loneliness, with a p for trend of less than 0.001. Loneliness and depressive symptoms had no significant associations with the development of vascular dementia. This slide is a redemonstration of the Cox regression models on a graph, again emphasizing the significant increases in relative risks for incident all-cause dementia as seen on the left and Alzheimer's disease seen to the right across the groups of depression, loneliness, and both. The presence of neither symptom was used as reference. As noted previously, we adjusted for relevant demographic and health-related confounders. In conclusion, we found that loneliness and depressive symptoms are predictors of both incident dementia and Alzheimer's disease, but not vascular dementia in older Japanese American men. Additionally, a combination of loneliness and depressive symptoms was more strongly associated with incident dementia and Alzheimer's disease than either predictor variable alone. On the other hand, neither loneliness nor depressive symptoms predicted increased vascular dementia risk after adjusting for covariates, which could possibly be explained by the subgroup being smaller than the all-cause dementia or Alzheimer's disease groups, and thus having limited interpretation of the 4-level composite group. It is not entirely clear whether loneliness and depression are early signs of dementia or modifiable risk factors for late life cognitive impairment. Regardless, addressing these factors early may help prevent dementia or its progression. Our study had several strengths, including its large sample size of over 2,000 subjects, adjustments for relevant confounders, including age, education, marital status, APOE for prior CVA and baseline cognition to ensure the reliability of our results, a relatively long follow-up period of 8 years with good adherence, in contrast to other studies with less than 5 years of follow-up and variable adherence patterns, and focus on a unique ethnic population, a seldom studied group. This emphasis on Japanese American men, however, also limited our study's generalizability. Other limitations included the observational nature of the study, which precludes conclusions about cause and effect, and the fact that we used predictors from only at one point in time. As such, we could not determine causality or chronicity of depression. Future studies could investigate the scope of the relationship of depression or loneliness in incident dementia in other ethnic groups and genders, as well as the potential impact of depression management and loneliness reduction on dementia risk, which could have lasting implications in the potential prevention or slowed progression of all-cause dementia and Alzheimer's disease. Thank you for listening.
Thank you, Crystal, for a wonderful presentation. We'll move on to our next project. And if people have questions, please put them in the chat box and we'll come to them at the very end. Devin, could you start putting up your slides, please? In the meantime, I'll introduce our last presenter. Dr. Devin Hazama is a geriatric medicine fellow with a professional interest in preventive medicine, healthcare disparities, and advanced care planning. In his free time, he enjoys hiking and eating shave ice, but most of his time nowadays is spent with his new puppy, Momo. After fellowship, he will be working at a federally qualified healthcare center on the Waianae Coast. Go ahead, Devin.
Yeah. Oh, thank you for the introduction, Dr. Masaki. Okay, can everyone see the presentation okay and hear me all right?
Yes, we can.
Oh, okay. All right, great. So, yeah, hello, everyone. Thank you for attending today's Grand Rounds. My name is Devin Hazama, and I'm a first-year geriatric fellow at the University of Hawaii. Today I'll be presenting on an abstract poster for a quality improvement project that was presented this past year's AGS conference. The title of my presentation is The 3 M's, Medication Management for Medis. First, I'd like to acknowledge my co-authors, Dr. Gina Fujikami, Emily Burns, and Christine Emoto, who did a lot of heavy lifting for this quality improvement project. Before I begin, I'd like to thank the Queen's Health Systems and the University of Hawaii for their support, as well as disclose that I have no commercial conflicts of interest. So the elderly population has a high incidence of polypharmacy, and there's a high correlation between the presence of medications and the number of medication discrepancies. As we know, medication side effects are a major cause, or can be a major cause of hospitalizations in the elderly population. One way we try to address this is through the medication reconciliation, which is a process of identifying the most accurate list of medications. So it includes data points like the name of the medication, dosage, frequency, and route that a patient is taking, and then comparing their medical record to an external list, which is obtained either from that patient, hospital, family member, pharmacy, or maybe another provider. However, the high incidence of polypharmacy, cognitive impairment, and transitions in care in the elderly population can create a significant barriers to appropriately completing medication reconciliation. So the objective of this quality improvement project was to reduce medication discrepancies in an elderly population with a high incidence of cognitive impairment. So for the methods of this quality improvement project, it took place from date of October 1st, 2019 to December 2nd, 2019. The intervention population was comprised of outpatient geriatric patients at the Queens Medical Center's geriatric clinic. And the analytical or the sample size of N was 156. For the intervention, participants were provided a medication bag and a printed medication list via mail, and this was given to them 1 week prior to their appointment. They were instructed to bring the medication bag and the list to their next visit. They then met with a pharmacist during their visit. So this is like a face-to-face visit where they completed a medication reconciliation. For our measured outcomes, that included medication, the number of medication discrepancies, patient experience outcomes, which were taken via survey and feedback, financial outcomes, such as the cost of time spent on medication reconciliation, and provider experience, and this was in the form of physician satisfaction feedback. So our data, so at the end of our intervention, we found that the percentage of patients who brought in their medications or a medication list for the reconciliation, it actually increased from an average of about 30.9%. As you can see over here in figure 1 on the left, and that increased to an average of about 83.1%. And then looking at medication discrepancies for figure 2 on the right, we found that the number of patients found to have an actual medication discrepancy, I think at least one, that increased from an average of about 45.4% to 88.1%. And then delving more deeper into the types of medication discrepancies, looking at figure 3 on the right, or sorry, on the left, we used the Pareto chart, and this actually showed that the types of medication discrepancies included unrecorded medications at 41%, discharged medications or discontinued medications at 38%, and then a change in dosage or frequency at 21%. And then looking at figure 4 on the right, In terms of data for patient experience outcomes, we found that about 92.5% of patients found the pharmacist visit helpful. 79.6% felt more knowledgeable about their medications, and 77.8% would like to see the pharmacist again. So in conclusion, after the implementation of our intervention, we found the average percentage of patients who brought in their medications or medication lists for reconciliation increased from an average of 30.9% to 83.1%. Looking at the medication discrepancies, we found that the average rate of finding a medication discrepancy increased from, let's say, about 45.4% to 88.1%. And last but not least, patients themselves, they reported finding the visit very helpful, feeling more knowledgeable about their medications, and a lot of them felt like they would like to see the pharmacist again at future visits. So finally, kind of building upon this project, future considerations could include collecting additional data points to identify correlations between things such as prescription fill rates from Medicare claims data. That would include like the number of prescribing physicians, medication classifications, such as, is it an over-the-counter medication? Is it a maintenance medication? Or even identifying if it includes high-risk medications. And lastly, trying to implement a clinic workflow, perhaps to identify and refer patients who may benefit from medication management. Okay, so, well, I think this concludes my presentation. So thank you everyone for your attention and listening.
Thank you, Devin. Very nice presentation also. And Dr. Fujikami says, great presentation. Kudos on your hard work. Thank you too, Dr. Fujikami, for your hard work on this project as well. We appreciate you as well, Dr. Fujikami. If there are any other questions for any of the speakers, please type them in the chat box. I'm going back a little bit. Dr. Wong is asking, Crystal, can you discuss the existing literature for your project?
Yeah, hi, thank you so much for your question, Dr. Wong. So for the start of this research, when we were looking through the literature, we had found a lot of studies looking at just dementia or Alzheimer's disease, or sometimes they wouldn't even specify, it would just be like cognitive decline, depression, if there's any relation with depression. But there wasn't very much on depression and specifically vascular dementia. And also for loneliness, there was not as much studies published that we found for loneliness, looking into loneliness and dementia compared to those with depression and dementia. And the ones we found were for Alzheimer's disease and cognitive decline. But we also did not find any studies that had looked at both loneliness and depression and its relation to dementia.
Thank you, Crystal. And Dr. Fishberg is asking, any thoughts on the difference between vascular dementia and Alzheimer's in your results?
Thank you, Dr. Fishberg, for your question. Yeah, so what we think could have happened with our results for the vascular dementia group was that the number of subjects with the vascular dementia were small compared to those with the Alzheimer's disease and all-cause dementia, and this I think that could have contributed to the significance of the finding for the vascular dementia group. And I wonder if the number of subjects for the vascular dementia were bigger, if the results may have been a little bit different.
Thank you. Any other questions for any of our fellows? If not, everyone, please join me in congratulating our awesome fellows who did a really wonderful job with their projects and with their presentations. Thank you, fellows. We are certainly going to miss those of you who are leaving us next year. We wish you all the best. You'll do us proud in your wonderful new careers. So thank you, everyone. Another reminder to please complete the evaluation for CMEs. The link is in the chat box. Okay, bye, everyone.